This presentation came out from an experience I had in one of our rural sites, and highlighted the experience in the rural site, highlighted my lack of knowledge, and provoked me to have a little poke about to see what was new with alcohol withdrawal and just how out of date I was. It turns out I am out of date, but to be up to date, I think probably I would have to roll back to the 1950s, which we'll chat about towards the end. Now, here we go. So just the sort of general approach, the textbook kind of thing. One of the tricks initially is to identify who really has withdrawal and do they actually require treatment. Certainly the vast majority of people we see with alcohol related troubles have crashed a car, fallen off something, or gotten in a fight. And generally, I think our approach is when they can walk and they can eat, and maybe somebody that cares about them shows up, they could probably go home. And I rarely think about them actually going into withdrawal, because I think for the most part, our population are binge drinkers. For the guys that are chronic drinkers, I realize that there's a few new things that we can try, which we'll get into, and that really a standardized approach to their symptoms and to the severity of those symptoms probably yields better results. Treating them fully before discharge, in retrospect, that probably is one of my key errors. And discussing or being aware of what potential harm reduction strategies there are available for quitting or harm reduction is probably useful. So to start off with, before everybody gets sleepy, I thought I would start with the sort of cool things that I learned through poking through this. But one that I tripped over that seemed kind of neat was for the mild cases, potentially discharging them home on gabapentin as opposed to a benzodiazepine. And benzodiazepines upon discharge seem to be a fairly common departmental practice, although when you read a little bit and look at other departments, it's definitely frowned upon. The other ones that I hadn't been doing, although I have given out a couple prescriptions over the course of the last year for naltrexone, but it has not been a routine for me, is using naltrexone not to prevent drinking, but to reduce drinking. And for those people that are able to enroll in an AA program or want to stop altogether, maybe the use of a camprosate. The moderate to severe guys, I think we're very comfortable using our CWA protocol, and that likely is a standard across most emergency departments. But there does seem to be a transition to using RAS, which I've noticed Tracy doing a little bit of education for our nursing staff on, and really looking for the guys that are in moderate to severe withdrawal to get a RAS of -1. So you say, hi, how are you? And they say, can I have another drink, kind of thing. At least they wake up to voice. And what about those guys that are in the community and just not ready to quit? And this has been on my mind with COVID, and I think has been in the papers, certainly for Toronto and some of the other places. But for the guys that live on the street that typically would leave against medical advice, it would be a challenge to contain COVID. So these creative guys came up with the idea of using alcohol, which is attractive to these guys that are addicted to alcohol, and providing it to them on an hourly to 2 hourly basis. And I wonder whether or not in those cases, whether there may be a role for naltrexone to decrease their use. I think that's just kind of a busy slide that you guys can have a look at any point. But really, to evaluate these guys, what I learned 30 years ago was that the CAGE questionnaire was adequate. We've now moved on to using an audit questionnaire. That's this one is just copied completely from UpToDate, but fairly widely available. But a few more questions on it than more than Cage. Just to highlight some of the managed alcohol programs, and Tracy was telling me about this in Ottawa. So the Shepherds of Good Hope have taken this another step further, aside from just providing the guys with controlled alcohol intake and getting control of their lives back, to actually, upon discharge, being discharged to a program where they not only get to continue to drink, but they actually get to make the drink. So they are brewing their own wine in this residential facility in which they live, which I thought was a fascinating move forward, and probably not something on the in the immediate future for New Brunswick after we spent all our money on COVID. Oops, what have I done? So for the guys that are ready to quit and maintain it, it's actually kind of hard to beat the Alcoholics Anonymous or a variation of the 12-step program. It is hard for some people to buy into with sort of religious overtones. But when compared with cognitive behavioral therapy or high price therapy, which physicians, when they develop problems with chronic alcohol use, are provided with, AA or 12-step actually seems to make out just as good or somewhat better when they're compared back to back. I think there will be a movement afoot to start incorporating acamprosate and naltrexone into most of these programs. So stage 1, these guys typically look a little anxious, restless, decreased attention. One thing that I did found that was kind of cool is the tremor is an intention tremor, and you can fake it, but it's hard to fake a trembling tongue. So if you're unsure, and I don't recollect having seen this, maybe you guys have, but you can ask them to stick out their tongue, and if their tongue is quivering at 7 to 14 hertz, and apparently that's quite unique to alcohol withdrawal. So that was a pearl for me, at least. Of course, insomnia and craving alcohol in the first stage. We're all familiar with using a CWA, and I guess the question that I had to myself that I realized it happens fairly commonly is, I'm not sure I believe the patients when I'm going through a CWA. It has a lot of subjective questions, and I think some of it can potentially be faked. So the gentleman that provoked my curiosity about how to properly manage alcohol is a 29-year-old gentleman named Cletus that showed up at this peripheral hospital. And the nurse that brought him in described him as being in quote unquote alcohol withdrawal, and he's shaking just sitting there. And I realized when he wasn't being watched, he actually wasn't shaking, which I thought was a little bit unusual. And he was specifically there to get some pills for his alcohol withdrawal, which struck me again as, a fair request, but got my radar up a little bit and wondered, is this actually truly a guy that's in alcohol withdrawal, or is he seeking something else? So he tells me that he had come to the department because he'd become frustrated trying to write. He could barely sign his name because his hands were so shaky. In fact, he said he had to slam back a couple bottles just to steady his hand. And he'd finally had become frustrated with this and thought that he would get it sorted out, and knew that he could get medications in the emergency department. Past medical history, as much as he would admit, hadn't involved any seizures or hospitalizations for psychiatric or addiction problems. He had mentioned that he had his appendix out and tonsil adenoids, smoked a pack a day, and worked as a clam digger. I was a little bit concerned that he might have driven himself to the hospital, but apparently he was wise enough to ask a girlfriend for a ride. So the mainstay of treatment, as he knew, and I thought I knew, was benzodiazepines. And that was certainly what he was interested in having a prescription for. I sort of thought, well, if I do accept that this is alcohol withdrawal, what would I give him as a CWAS score? And I thought, really, he's a bit anxious, but he's not really scoring anywhere else that, didn't really have a headache, wasn't even particularly nauseated. And though I wasn't saying it, I did wonder whether or not he may have been performing in order to obtain a prescription. I didn't know to look at his tongue at the time. Maybe that would have helped. But yes, the tongue tremor I will be on the lookout for in the future. I did wonder about reporting him to DMV. I didn't, and that probably was a shortcoming, but I was reassured that the guy was actually alert, oriented, able to walk normally, seemed to be able to drink water without difficulty, and in fact wasn't driving at the time. So I didn't report him to DMV at the time. And it did cause me to wonder afterwards how high the bar is for that report. And I think if you believe somebody is in the midst of alcohol dependence on a daily basis, I think we probably do need to report and leave it to the family physician or one of our detox colleagues to provide a notification of DMV when they're felt to be safe. But looking at the CMA's guidelines, they're a little bit vague. It really is a lot on the shoulders of us to decide who is safe and who's not safe. And we're not policemen. So in any case, Cletus did get to go home with his driver's license with his girlfriend. However, I was uncomfortable giving the benzodiazepines, and I'd vaguely remembered hearing a quick hits on EM cases about gabapentin, and quickly Googled through and fortunately tripped into a nice routine on UpToDate. So it is actually fair treatment for mild withdrawal symptoms. And you can see down at the bottom of the UpToDate protocol that they had a nice abbreviated short one that's kind of done and dusted in 4 days. So 300 milligrams every 6 hours, then 300 milligrams every 8 hours, and then 300 milligrams Q12 and one dose of 300. So I thought, this is great. I'm happy because I'm not prescribing what I perceive to be an intoxicant. And he seems happy because he's getting a prescription for a pill that's supposed to help withdrawal. And I was further reassured in that he said, like most of our patients seem to do in RAS, had an appointment to see his family doctor the next day in any case. And just a note at the bottom there regarding thiamine use prophylactically for Wernicke's, and at least managed to search around to see what was available in the community for support systems, of which there were a few. And just as a curiosity, discovered that there is a AA in St. Andrews that is secret and is only available by appointment and with a special handshake and such, which unfortunately I don't know. So I felt with all of that information, he was ready for discharge. So off he toddled. Now, the other things that I didn't provide him, and I'd mentioned at least in the introduction, was potentially using a acamprosate and naltrexone for these guys. It's impressive that really there's a number needed to treat of 12. So I don't think this is yet routine in our department, but maybe we should be looking into doing it somewhat more frequently. I think the naltrexone is considerably easier because it's just 50 milligrams once a day. And its goal is harm reduction, although it may help some people stop. And the side effects are really fairly minimal. Acamprosate, on the other hand, is 2 pills 3 times a day. So as you can appreciate, compliance is an issue. That naltrexone likely will win in the end because it's now becoming available as a once a month injectable medication. Stage 2, an hour, a day or so later, where we're looking for the hallucinations, confused, hypervigilant, irritable. I don't see a lot of these guys. And if I do, I probably confuse the diagnosis with something else, like being intoxicated or potentially on meth. A couple days later, unfortunately, Cletus reappeared at the Death Star Emergency Department. And as I came on shift, I recognized his pretty face sitting in the corner. and spoke with one of my colleagues who advised me that, in fact, he had had a seizure and he was doing fine now. So I didn't feel great after that one. I don't think Cletus got into this, but the more dramatic, which I've seen two that leaped to mind, one of whom tried to hang himself in our old department in a back room and looked like he was possessed by the devil and fighting extremely aggressively. And the other just so absolutely agitated that he took two cops and a couple of our security people to restrain long enough that we could bang in, at least at that time, midazolam IM. So there are screening tools beyond cage, and I really like simple things. And this one question approach I thought was a wonderful one to incorporate routinely in history and physical. And simply asking, how many times in the past year have you had more than 5 drinks if it's a man, or 4 drinks for a woman? And if you get a yes to that, well, it's obviously a fairly sensitive question, not terribly specific, but may provoke you to go on to do a pause score, which is a prediction of alcohol withdrawal that's going to require intervention. So I won't belabor it, but some of the key points are, have they experienced previous alcohol withdrawal, or have they had previous seizures, or any history of delirium tremens? Coadjustance is huge, or a concurrent addiction is huge. In any case, this is just something potentially to reach for. Really, it's looked at more for our inpatients who's likely to get into trouble. So maybe something for our internal medicine or hospitalist program to look at. So delirium tremens, that's the end stage, 48, 96 hours, can be even longer than that. But just delirious, agitated, tachycardic, hypertensive, potentially febrile, diaphoretic. It certainly sounds to me like they would fulfill criteria for SIRS or a serious infection of some kind. So you can appreciate that there's a significant differential there. And once they get to that stage, I think the question really is this an HMP issue or is this an ABC issue? You need to get control of that severely agitated patient. And to do that, again, benzos are considered safe, but increasingly and appropriately, we're using ketamine, either IM or IV, to get rapid control and at least time then to either start with benzodiazepines or potentially phenobarbital. I'm not going to belabor the history and physical, which you guys are quite capable of obtaining yourself and recognizing that there's a significant differential. Just another pearl that I think I might have known at one point, but either forgot and was reminded through setting this up. But for the Wernicke encephalopathy guys, they don't have to have all 3 things at one time. They can have had a history of ocular motor, just a function that's come and gone, a gait ataxia that's come and gone, and an encephalopathy that may present at the same time or may not. So this is, of course, very familiar to our department, so the CWAL that we currently use, and appreciate that just how much of that really is subjective for our nursing staff to evaluate. And the inter-rater reliability is unavoidably going to be quite large. There's some thought of making life simpler for emergency physicians and using a shot protocol. And it's unfortunately not validated yet, but looking at objective things, somewhat objective things, I guess hallucinations are not, but sweating, asking if you're hallucinating, are they orientated, and is there an intention tremor? Where this is going, I think, is probably using a RAS score, and whatever you choose to use as medication, looking for a -1. So awakens to voice with eye opening for at least more than 10 seconds. In terms of drug use, I've been guilty up until this point of largely using lorazepam, which is, I think, quite simply wrong. It is on our CWA score sheet and it's given as an option for us may be appropriate in the guys that have liver failure, which is actually not a large number of our patient population. I hadn't been using a whole lot of Valium, which seems like a much better choice because of its long half-life and its rapid absorption. The more recent, but the cool kids on the block are starting to use, and I think I've heard come out of Liam's mouth, which means that it must be right, is that phenobarb is the future. And phenobarb is also the past. That was the drug that was used back in the 1950s for rum fits. So currently, this is what we have. We're given a choice of diazepam, lorazepam, or oxazepam. When you look at other departments' protocols, they actually don't have lorazepam or oxazepam on there. It's just diazepam. So alcohol may not have all the answers, but it can make you forget the questions. So phenobarb from the 1950s, nice drug. Has a fairly rapid onset of action and a long duration activity, so that they have a they essentially self-taper over the course of the subsequent week or so. A couple kind of cool protocols. This one comes from PalmCrit, from a guy named Josh Farkas. And they almost exclusively use phenobarbital. And they decide initially as a patient had benzodiazepines or other sedating medications, what is your differential? And they give a 10 mg per kg loading dose based upon ideal weight, and then proceed through the algorithm as you see there. But really, again, with the goal of a RAS of -1. The sort of variation upon that out of Scott Weingart and E.M. Crit, in which they're using a combination of benzodiazepines and then failing, if it's unsuccessful, switching over to phenobarbital, which I thought is probably more realistic because I don't think there's a lot of comfort right now in our department, or at least for myself, because I haven't used phenobarbital since I attempted to euthanize a kitty cat that an RCMP officer presented me with in rural Newfoundland after he thought there was a loud screeching beneath his hood, starting it up on a cold fall day. Phenobarb didn't work very well for euthanasia, incidentally. Potentially PO options for phenobarb, and again, this was the original studies looking at rum fits. They were actually based, which would never get past ethics now, but on 10 gentlemen that had stopped using heroin and were substituted with as much alcohol as they could enjoy, and of course got hugely hooked on it. And when they got into withdrawal, were simply given a gram of phenobarbital, and for what it's worth, all 10 seemed to do fine. So if the guys that really are above and beyond, seizing, can't control them, ketamine, propofol, our ICU colleagues have dexmedetomidine, but really it's working on the peripheral symptoms as opposed to the central symptoms, and I don't think is really ever going to be a drug for us. So I think the key ones for us in this table are going to be ketamine and probably propofol, and maybe eventually phenobarbital. So that's my brief romp through alcohol withdrawal, and just a couple of what's I think kind of interesting and new and somewhat hopeful. So any questions or feedback?
Thanks.